Morning. The topic of my presentation is outcomes after Desmet stripping automated endothelial keratoplasty in patients with Aurolab Aqueous Drainage implant insertion. To begin with, there is increasing use of GDDs to control intraocular pressure in glaucoma patients, which has been attributed to their relatively good safety profile. Endothelial failure in patients with GDD occurs secondary to cornea tube touch, intermittent or persistently high IOP, and or surgically induced endothelial cell loss, especially after multiple procedures. Penetrating keratoplasty, as we all know, has been outweighed by DSAEK as the most widely performed endothelial keratoplasty for endothelial diseases over the last decade, though DSAEK is more challenging in such cases. So this was a retrospective case analysis done in a tertiary eye care center operated by a single surgeon on 4 cases. The minimum follow-up was of 6 months. We assessed the indications, medical and surgical treatment of glaucoma, IOP changes before and after surgery, post-operative visual outcomes and complications. Surgical technique, we used a Moria microkeratome for button preparation. Temporal tunnel, 5 mm was clear corneal tunnel was made. Desmetorexis was done using reverse Sinski. Tube shortening wherever required was done. The Trifine button was inserted into the anterior chamber by use of, it was glide-assisted sliding of the lenticule. Air bubble was injected and the wound was closed using Tenno nylon sutures. 100% air bubble was injected at the end of the surgery to achieve an effective tamponade. This is one of the post-op 3 months follow-up of one of our cases. So coming to the results, the patients were, 4 patients were in the age group of 55 to 65 years of age. All had a prior RD in situ. One patient had TRAB followed by RD and the other patient had TRAB followed by double consecutive RDs. The indication in all the 4 cases was different, being a PXF glaucoma, primary angle closure glaucoma, primary open angle glaucoma, traumatic glaucoma. The intraocular pressure was well under control in all the patients, with 2 requiring additional anti-glaucoma medications. The visual prognosis was good, with 1 patient achieving up to 6/9 vision post-operatively and 2 patients achieving 6/36. 1 patient did not improve because of primary graft failure. One of the cases we noted early graft dislocation on post-operative day 2, which was successfully managed by rebubbling. Coming to the discussion, the study shows that the DSAEK is an effective procedure to restore visual function from endothelial failure in eyes with prior RD implantation. Post-operative breast-corrected visual acuity improved in all cases except one, which had primary graft failure. One of the patients had post-operative graft detachment, which required rebubbling, compared to other series which also required rebubbling in percentages from 26 to 39%. These findings are consistent with the frequently described phenomena of GDD predisposing to leakage of the flotation air bubble. So the air management in these cases is the most difficult because the air tends to escape from the GDD tube into the subconjunctival tube. And trimming of GDD tube within the anterior chamber to prevent contact with the graft may be necessary in some patients to achieve successful DSAEK, and 2 of our patients needed this. Our study showed 1 DSAEK failure, which is in line with the study by Kim P. et al. Eyes with multiple glaucoma filtration surgeries are more likely to have difficult to control glaucoma, which may increase the predisposition to DSAEK graft failure, as seen in our case with primary graft failure. Also in these cases, there is an altered anterior chamber environment. There's alterations in the proteomics. There is increased oxidation, apoptosis. So these patients are very difficult to manage. No IOP spikes were noted. To conclude, I would like to say DSAEK in eyes with corneal edema secondary to endothelial dysfunction in the presence of a previous GDD is a successful procedure, though being technically more challenging. Thank you.
The eye which had the graft detachment, was that the one that failed subsequently?
No, ma'am. It was the TRAB with consecutive RD, which had graft detachment, but it survived. So the vision in that case was 6/36. The primary graft failure happened in the case with TRAB with consecutive RD implantation. So it was a pseudophakic eye. Like there were multiple surgeries, 4 surgeries done in that eye. So
How long would you wait after a tube to know that the app is under control and you can safely go ahead and do a EK procedure?
Ma'am, I didn't get you, ma'am.
How long would you wait after the implant, after the valve implantation? How long would you wait before to take up the patient
To take up the patient
for a DSEC?
DSAEK.
Yeah.
Ma'am, as soon as these cases were all having corneal decompensation. So it usually happened after 3 to 4 years of implant. It was not like RD insertion.
Okay. And what was your post-op steroid regimen in after the EK?
Steroids, we usually give 4 times. Uh, Antibiotic steroids, we usually give gatifloxacin and prednisolone 4 times per day for 15 days and then taper at monthly intervals. And these patients also, we started anti-glaucoma medications post-op for 1 month, and then if needed, the anti-glaucoma medications were continued, and then if not needed, they were stopped.
So all these glaucoma drainage devices were used, implanted using limbal route or somewhere from past lunar route also?
Yes, sir, limbal route. All.
And did you compare the outcome of DSEK in these cases where implant has already been put in to the cases where no implants are there, means routine DSEK cases like endothelial cell counts and thickness, and what duration was there to get it clear?
Ma'am, in these like all our DSEC, without the RD implantations also, whatever we've seen in our OPD is like 3 months. The best corrected visual acuity at 3 months will be like initially it will take the graft to survive. So after 3 months only they'll have clear grafts and like good vision.
And what was the difference in the survival of both the types?
Definitely in non-glaucoma eyes, the survival rate is much more higher than compared to. This was the 4 cases that we studied were 2 years back. Now the surgeon is doing a lot of surgeries like DSEC in RD. So definitely the DSEC survival in non-glaucoma eyes is more.
And what is the longest follow-up in your case?
2 years, ma'am.
2 years.